Hi everyone. Today we're going to be talking about clinical advances in musculoskeletal sonography. First and foremost, I'd like to thank the Candi Society of Medicine and Dr. Asela for inviting me to give this presentation. It's an honor and a privilege to share my experience in musculoskeletal ultrasound with the Candi Society. My name is Dr. Dinesh Sirisena. I'm a consultant in musculoskeletal, sports and exercise medicine, and I am currently practicing in Singapore. I undertook my sports medicine training in the UK, and along the way I have incorporated musculoskeletal ultrasound into my practice, and I use it on an almost daily basis. Just to share with you, this is my YouTube channel, and there are lots of resources on the YouTube channel for those of you who are interested in musculoskeletal ultrasound. There's the basics and fundamentals of imaging, as well as how to scan and inject different areas. And there's also cases that I've shared of patients who have come into the clinic and who I've seen along the way. For those of you who are interested, there's also the book I published in 2021 named Ultrasound-guided Musculoskeletal Procedures in Sports Medicine. Fortunate enough to be accepted by Elsevier to publish the book. Finally, there's a free resource which is available to everybody. There's no subscription required, and that's sportsmedinfo.sg. Please take a look at it. There's lots and lots of resources for medical practitioners as well as patients, and I hope you find it useful for everyone. Ultrasound is an important tool for the musculoskeletal practitioner. Not only can you assess soft tissue structures, but you can also perform interventional procedures, and in some cases you may even see bony pathologies. To start appreciating musculoskeletal ultrasound, or ultrasound in general, it's important to have an understanding of the science behind ultrasound. The essential component in the ultrasound unit is the transducer, and we have various parts to it. There's the piezoelectric crystals at the very head, then you have the body of the transducer and the connecting cable which connects the transducer to the main unit. And this is essentially how ultrasound works. So we will have an electric current that is sent across the piezoelectric crystals. It will emit a sound wave out to a structure, and when it hits a particular structure, it will get reflected back. And then the computer on board analyzes what is happening, how deep the structure is, the nature of the structure, and the sound waves returning, and then it creates an image. For structures that are deeper, the sound wave will obviously travel much further, and you will receive an attenuated signal back. For structures where there is water, you might get a phenomenon called post-acoustic enhancement, where the structure with water in it is brighter at the bottom of the image as opposed to where the sound waves are coming in from. And typically, when you have sound waves going through a structure with air in it, you won't be able to see anything at all. Now, this sounds counterintuitive because obviously I'm sitting here, I'm talking, and you're hearing what I'm saying, and we're listening through our ears. But ultrasound waves are very different. Because of the high frequency, they cannot penetrate the air tissue so well, and as a consequence, you don't get any image at all. Let's take a look a little bit more at the controls of the ultrasound. Now, the ultrasound machine in this picture is a GES7, which looks very complicated, but let's break it down to the essential controls that you would need if you are going in to use musculoskeletal ultrasound. Firstly, you need to select the correct probe. Different probes or transducers have different functions. The higher frequency, smaller hockey stick transducer is very useful for superficial structures, whereas the curvilinear low frequency transducer is more useful for deeper structures. In musculoskeletal medicine, this may be structures such as the hip or the spine, and in contrast, for the hockey stick transducer, you may look at structures around the hand or the feet. When you select the transducer, it's also important to select the correct setting. Because ultrasound is used for a wide variety of different purposes, from cardiac to breast to even fetal scanning, it's important to ensure that you have the machine set on the correct settings so that when you are undertaking the images, it's optimized. It doesn't mean that there isn't room for adjustment, but as a baseline, it's important to go with the settings for the function that you're hoping to use it for. The next important thing to talk about is the focus. Much like on a camera where you're trying to sharpen the image, in ultrasound, what you're doing is you're trying to concentrate the waves to a particular area or structure so that there's more sound waves going into that area, and hence the picture that you get back is sharper. As the structure gets deeper, you may need to adjust the focus so that it follows it. And it's usual that we put the focus slightly beneath the area of interest so that the sound waves concentrate on the area of interest, and then we get the optimal image back. Some machines have multifocal functions. While this is great and you get a sharp image throughout, it does mean that the return of the signal is slower, and so the frame rate and the picture may be a bit slow. Next, we have the depth, which in some ways you can think of as a field of view. Now essentially, here in the picture, we see that the structure that we're interested in is not in the field of view. Whereas when we increase the depth, we can see that it's in the field of view, and we can assess the structures around it as well. Moving forward, we have the gain. Now the gain is a bit like the aperture on a camera. In terms of the aperture, the wider the gain or the bigger the aperture, the more light comes in. In ultrasound, what this means is the higher the gain, the more sound waves comes in. And while that might seem a good idea because you're getting more sound waves back, what you'll also be doing is getting a lot more noise. And here is an example. So on the left side, we have an image where the gain has been increased, and we're looking at the quadriceps. So we have the femur here, we have the vastus intermedius and the rectus femoris. Now with the gain increased, obviously the picture is brighter, but actually is much more difficult to differentiate the muscle boundaries and the different structures. When we reduce the gain in this situation, we can see the bone much more clearly, and we can see the boundary between the muscles much more clearly as well. The next function that we want to consider is the frequency. Now, as I mentioned earlier, when selecting the transducer, you have the high frequency hockey stick and the low frequency curvilinear. And these have different functions. So high frequency has low penetration but higher resolution, and low frequency has higher penetration but lower resolution. So the high frequency transducers are really useful for superficial structures. As I mentioned, the hand or the foot, or maybe even the ankle. The low frequency transducers are much more useful for deeper structures such as the hip, maybe the shoulder joint, or even the spine. By adjusting the frequency, you can make the image sharper and darker, or brighter but less clear. Depending on the depth of the structure that you're looking at, you may need to go either way. Finally, there is freeze. Now the freeze function doesn't sound like a really important tool to know about, but it is really important when you are scanning a patient, you've identified some pathology or abnormality, and you want to stop the image so that you can explain to the patient what's happening. Without knowing where the freeze function is on your machine, you'll be looking around for it, you look away, and then suddenly the image is gone. So identifying where the freeze function is on your machine is imperative. So to optimize your image, you need to have a consideration of various things. Firstly, the transducer, the settings of the transducer, the frequency, the aperture, the gain, and the depth. When considering ultrasound as well, it's important to have a think about the machine that you're going to be using. There's a whole variety of different models, ranging from pedestal models with many different functions to portable tablet versions. What you need to do is understand what purpose you're going to be using it for. So if you are going to be using it for diagnostics, then it is important to have a machine with reasonable function and resolution. If you're looking at it from a more basic assessment perspective, say the pitch side, or if you're going to be using it for very basic interventions, then perhaps a tablet would be appropriate to use. It also depends on the budget that you have in mind. As we go up towards the pedestal machines, obviously the price will increase. But with that comes functionality and a greater degree of accuracy in terms of your imaging. And this is an example of a tablet. So we have the Philips Lumify, which has curvilinear, linear transducers, and you attach it to the tablet, and then you get the images from there. Another consideration is storage of the images, whether it's stored locally or on a cloud. And so, again, another consideration after that is the safety and the security of images and patient data. If you do want to know more about portable tablet-based systems, I have some videos on my YouTube channel which you can refer back to. As I mentioned earlier, the transducer is an important criteria to select. Here we have the curvilinear transducer with a low frequency and broad field of view. We have the hockey stick transducer with the high frequency and a very narrow field of view. And then we have two examples of linear transducers, one which is higher frequency and one which is lower frequency. Both have a similar footprint, but because of the difference in frequency, the penetration and resolution of each will be different. This slide is just to highlight the importance of selecting the correct transducer. We're scanning my wrist in all three examples, and looking with the curvilinear transducer, you really don't get any sharpness or clarity of the bones or the tendinous structures at all. With a linear transducer, you can certainly see more, but with the hockey stick transducer, you see the most detail, and you can almost see the fibrils of the tendons as it runs across the bone. One of the key uses in musculoskeletal medicine is when you're assessing muscles, ligaments, tendons, and looking for changes such as degenerative joint disease, synovitis, or joint effusions. Here is an example of an ultrasound scan of the quadriceps. On the left, we can see the long axis view. So we see the rectus femoris and we see the vastus intermedius here. When assessing the muscle, we're looking for the overall integrity, we're looking for the thickness of the muscle, we're looking for the fascial planes in between and the fascicles of the muscle to make sure that they're going continuously in one direction. It's also important to have a look at the muscle in a short axis orientation. Sometimes the short axis orientation is actually very valuable for looking for tears. What I normally do in this situation is place the transducer in a short axis orientation and run the transducer up and down the muscle to see if there's any obvious glaring tears or disruptions of the muscle that can be seen. Once you've identified a pathology, you can change the transducer into a long axis orientation and then have a look at it in more detail. When evaluating it, it's important to measure the disruption or injury in both the long and short axis. Here we have an example of a patella tendon. Again, we can see with a linear transducer the linearity of the tendon. We can see the fibrils. Beneath it, we can see the fat pad, and we can see that the tendon attaches from the patella down to the tibia here as well. Again, it's important not only to assess the tendon in a long axis orientation, but also a short axis orientation as well. In both orientations, you must measure the thickness and assess any pathologies that you may see. Ligaments can also be evaluated using ultrasound. Because of the superficial nature of ligaments, I would suggest using a hockey stick transducer, as this will give you the highest resolution and the sharpest image. In this image, we see the anterior talofibular ligament. Here we have the fibula, here we have the talus, and in between we have this linear structure running. In situations where there's injury, there may be disruption of the ligament as well as an effusion sitting beneath it. You can also use ultrasound to assess nerves. In this image, we have the carpal tunnel. So we have the flexor retinaculum running between the wrist bones, and beneath it we have the median nerve as well as the flexor tendons. Again, it's important to assess nerve structures at the area of interest in a short axis orientation as well as in a long axis orientation. Beneath, we can see the median nerve in a long axis orientation, and what we're looking for is any thickening or disruption of the nerve itself. Finally, we can have a look at bones and joints. Now, the challenge with ultrasound is that sound waves get reflected from bones, so we cannot assess the bone in a great deal of detail. However, we can look at the surface and make assumptions from there. In the bottom picture here, we have an evidence of a stress fracture. So you can see the cortex is broken, and in situations such as with children where you don't want to expose them unnecessarily to radiation, you can undertake an ultrasound to see if there is that disruption of the bone. We can also see in the bigger image the ankle joint. Here we have the tibia, we have the talus, and then further down is the navicular. When we're looking at the joint, we want to see, is there any degenerative changes, any synovial thickening, any effusion, and such forth. So overall, there's lots and lots of different things that we can be looking at in terms of the musculoskeletal system. We can look for muscle tears, myositis ossificans, fascial thickenings. With the tendons, we can be looking for tendinopathy or tears. We can look for joint effusions, soft tissue edema or abscesses. We can also look for ligament tears or thickening. And we can also have a look for periosteal thickening and fractures in bones. So the next few slides, we'll have a look at some quick examples of types of pathology. Here we have a gastrocnemius tear. So as you can see, there's a hypoechogenic change within the body of the muscle, and there's hyperechogenic changes surrounding it. This image is in a short axis orientation, and therefore it's important to flip the transducer 90 degrees and then have a look at it in a long axis orientation as well. If you have a particular function on the ultrasound called a logic or panoramic view, you can assess it in a wider field of view, which allows you to take true measurements of the length of the injury. Tendon pathologies are bread and butter in musculoskeletal ultrasound, and here we have an example of an Achilles disruption. So in the top image, we have an anterior portion tear of the Achilles, and on the bottom image, we have a full thickness tear of the Achilles tendon. Again, it's important to measure and assess these changes or pathologies in a short as well as long axis orientation. Superficial ligaments of the knee can be readily assessed using ultrasound as well. The medial collateral ligament is commonly injured through valgus stress in sport, and it can cause significant pain, limitation in movement, and even swelling in the soft tissue. In this image, we can see the medial collateral ligament. And remember, there are two components to the medial collateral ligament, the superficial and deep. In this situation, we can see that there is hypoechogenic changes around the medial collateral ligament in keeping with a disruption of it. We can also look at nerve pathologies. So this image is of a sciatic nerve transection. You can see the proximal part of the nerve, and you can see the distal part of the nerve, and you can see this hypoechogenic disruption in between. In some situations, you can also assess if there is impingement of the nerve. We've already had a look at what the carpal tunnel looks like, but there are other situations where the nerve can be impinged, such as with piriformis syndrome. In this, the sciatic nerve runs through the piriformis muscle and gets squeezed, causing pain to radiate down the leg. Now, let's move on to some interventions in musculoskeletal medicine. And this is something that's really come a long way over the last 10 to 15 years. One of the traditional treatments that we used a lot is steroid. Steroid has its purpose, and while it has got a bad name in the general public, it is a very useful treatment, particularly when there's synovitis, maybe on the background of rheumatoid arthritis or gout, or whether there's acute pain which is inhibiting function. It's a good idea to obviously learn to scan the structure before you put steroid around it, because if there's any tearing of it, the side effect of the steroid may be to weaken it further. So checking the structure is intact or just irritated before undertaking the steroid injection is important, and then placing the steroid as close as possible to the structure but not within it so that it disrupts it is useful. This is where musculoskeletal ultrasound has really made many changes. There's lots of evidence to say that doing blind injections is a far cry from ultrasound-guided, and you can really place the steroid in a better location using ultrasound guidance than blind injections. Another treatment commonly used for degenerative joint disease is hyaluronic acid. Hyaluronic acid is a large branched molecule which draws water into the joint when it's injected in there and creates a cushioning effect. It can be used for degenerative joint disease, and some people even use it preventatively, particularly elite athletes who are running a lot and putting a lot of stress through their joints. By drawing water in, the hyaluronic acid creates a cushioning effect in the joint and serves to protect it, but it also reduces pain. The next treatment that is important is platelet-rich plasma, and this is something that I do a lot of in my clinical practice. Platelet-rich plasma is essentially where we take the patient's own blood, we centrifuge it, and separate out the red cells from the plasma and the platelets. Using various concentrations of the platelet-rich plasma, we then inject it into muscle tissue, tendons, ligaments, and even joints. The PRP has three purposes. Firstly, to reduce pain. Secondly, to reduce inflammation. And finally, to try and stimulate some healing of that area. I use it a lot in my own clinical practice for a variety of sports as well as degenerative musculoskeletal conditions, and it has very good use. In terms of musculoskeletal medicine, there's good evidence for lateral epicondylitis as well as knee osteoarthritis. There's moderate to high quality evidence for patellar tendinopathies, plantar fasciitis, as well as intraoperative ACL reconstruction. And there's not so great evidence for rotator cuff pathologies as well as hip osteoarthritis. One of the challenges of research in platelet-rich plasma is the standardization. My PRP and my platelet retrieval will be different to somebody else's, and equally the different systems that are available will produce different concentrations of platelet-rich plasma. Unless there is a way to standardize it, it's going to be very, very challenging to give really, really high quality randomized control studies and really good evidence. Nonetheless, in my own clinical practice, I have used it for all of these pathologies before, and I have had very good results from them. For those of you who are interested, some years ago there was a consensus statement by ESCA, which is the European Society for Sports Traumatology and Knee Surgery. And they put together the consensus statement for the use of PRP in degenerative knee osteoarthritis. Their main conclusions were that PRP was an effective treatment for knee osteoarthritis from a symptomatic perspective. And even in patients with Kellgren-Lawrence stage 4 degenerative joint disease, there's no harm in trying PRP as a first step before going on to more surgical intervention. There's also been some discussion about the difference in use of PRP versus hyaluronic acid for degenerative joint disease. It's generally been found that PRP is more efficacious than hyaluronic acid on the short and long term, and the duration of effect does last longer. However, in my own clinical practice, I tend to use both together. The reason for this is the PRP generally helps with pain, inflammation, and hopefully helps to heal a particular area, whereas the hyaluronic acid helps with cushioning and filling in that space to allow the area to function that little bit more. Therefore, combined, we're getting the best out of both treatments. Another treatment that's available for the musculoskeletal practitioner using ultrasound guidance is prolotherapy. Now, some people do prolotherapy injections without ultrasound guidance, but I feel personally that it's much more effective if you can see where you're going and be more targeted in your approach. There's various substrates that you can use for prolotherapy, such as glycerin, dextrose with local anesthetic, dextrose alone, or phenol. Essentially, when you inject the prolotherapy into a particular area, you're trying to create an irritation and inflammatory response in that area to stimulate the body to come and heal it. Prolotherapy is thought to be as effective as PRP in terms of treatment outcomes. However, in many situations that I have used in clinical practice, you often have to do repeated treatments with the prolotherapy to be effective. Whereas with the PRP, you tend not to have to do so many treatments. So this is just a little table with the various interventions that I use in my clinical practice, with an emphasis on the purpose, the onset of effect, the duration, and any advice that you might want to give the patient post-procedure. This may be a useful slide for you to keep hold of when you are discussing it with your own patients. Another ultrasound-guided treatment which is incredibly useful in musculoskeletal medicine is the 10X. Now 10X in some ways, and if you want to think about it in a very easy to understand way is shockwave through a needle. Essentially, 10x uses photoemulsification technology, where an ultrasound energy is emitted into the tissue. It debrides the tissue with a jackhammer sort of approach, and then it takes out the debrided tissue. It's essentially like a tenotomy, but using a ultrasound to guide you to a particular spot. It's minimally invasive, and it has a real use in patients with recalcitrant tendinopathies or patients with plantar fasciitis, which is not recovering despite repeated treatments. So the early research in 10x was undertaken for tennis elbow, particularly those which are not healing so well. It was found that not only did the pain improve over a period of time, but also the tendon started to look more like the normal tendon tissue after the 10x treatment. So in terms of my approach to tendinopathy, particularly in chronic cases or where there's degenerative changes, I would say that PRP or 10x are my first line as opposed to anything else like steroid injections. So just to recap, ultrasound is an important tool for sports physicians. We consider it as our musculoskeletal stethoscope, and it allows us to support our clinical assessment of patients in a much more detailed and immediate way. It allows early assessment in the clinic setting, and it also enables us to undertake guided interventions. The advantage of it is that we keep things minimally invasive and we are much more focused in our approach, but also we can use ultrasound as a tool to monitor recovery. Thank you again to the Candi Society of Medicine for inviting me to give this talk. And I hope I've given you an overview of the real importance of ultrasound in musculoskeletal medicine, and in particular for sports physicians. And if you are interested in further videos, please remember to have a look at the YouTube channel. And there's a plethora of different videos there, from scanning to cases as well.